Man, we'll go live in 30 seconds. Aman, you can start.
Good evening, everyone. We take a great pleasure in bringing you this educational program, Planet, program on learning and updates in neuropathic pain. The Planet program is specially designed for you to learn advanced and updated facets in the management of neuropathic pain. Today, we have with us Dr. Pravesh Kantak, Director of Meru Spine and Pain Center, Indore, Head of Pain Medicine, Choitram Hospital and Research Center, Indore, MBBS, DA, DNB, FIPP, Budapest, Hungary 2010, FIAPM, first and the only one in the world, whole of Central India to be awarded FIPP, Fellowship Program from World Institute of Pain and American Board of Pain Management, written chapters in many books, actively involved in teaching and training of pain physicians, area of interest, conservative and minimally invasive treatment of spine pain, National Secretary of Indian Society for Study of Pain, ISSP. I would now request Dr. Pravesh to take this session forward.
Yeah, very good evening, Aman. So, hi friends, this is Dr. Pravesh Kanthhed. So, I happen to be the National Secretary of Indian Society for the Study of Pain. So, basically, our society is the largest body of pain physicians in India, and we deal with diagnosis and treatment of pain-related disorders. So, in this Planet program today, we are having a discussion and a webinar on diabetic peripheral neuropathy. And the speaker for today is Dr. Krishna Poddar. And I'm very happy to welcome her and introduce her to all of you. So she has done her MD and she is FIPM and FIAPM. So FIAPM is basically a fellowship for Indian Academy of Pain Medicine. She has a lot of things to her credit. I'll just name a few of them. So she is the Times of India Healthcare Pioneer Award for the East in 2020 in the field of pain medicine. She is Director of Kolkata Pain Clinic and Associate Professor in the Department of Pain at WIMS. She is Visiting Consultant in Pain and Palliative Care in Central Hospital and as well as in Fortis Hospital. And last but not the least, she is currently our Vice President. She is the Vice President of Indian Society for Study of Pain. So over to Dr. Krishna Poddar for an enlightening talk on diabetic peripheral neuropathy. Over to you, madam.
Thank you, Pravesh, and thank you all. And good evening to everyone. It's my pleasure to present in front of you for the diabetic peripheral neuropathy. As diabetic peripheral neuropathy is a very common thing. Why? Because in our country, the diabetes is the most common problem. If you see it, every second person is the diabetic. Even to be surprised, all the youngster, if I see 25, 30 years of the age, they are diabetic. And elderly also. So in family, if you see there are 4 people, maybe 3 are the diabetic. So it is very prevalent. And not only on the, even the rural areas, the diabetes is now very common. So it is a big problem. With the diabetes, neuropathy again is a common problem. So diabetes has reached the epidemic proportion worldwide. And even IDF estimates suggesting prevalence of the 425 million people worldwide in 2070, rising to 628 million by 2045. And in India, in fact, the developing countries are the most common problem with the diabetes. I get most of the patients from Bangladesh, and to my surprise, all patients are diabetic. If they come like 30, 35, 40, everyone has the diabetes. Indian population has also a endemic for the diabetic. And this will be accompanied by an increase in the prevalence of the complication of the diabetes also. So what is a diabetic peripheral neuropathy? So if you see, it is a symmetrical length dependent sensory motor polyneuropathy, because you have to identify which is the diabetic peripheral neuropathy. Because in diabetic patient, the other peripheral neuropathy can occur, like maybe the radiculopathy or other diseases which are associated with the peripheral neuropathy. So we have to know what is a diabetic peripheral neuropathy before we say this patient is having the diabetic neuropathy. So it is symmetrical, same with the length dependent. Some patient has only the few fingers, some has only the foot, some has the leg up to the knee, but mostly knee, up to the knee. And sometimes some patients say even the full leg. And it is a sensory motor polyneuropathy. So main problem is here, what is the reason is the metabolic and microvascular alteration because of the diabetes. So why it is happening? Because of the chronic hyperglycemia and cardiovascular risk cohorts. So diabetic polyneuropathy is characterized by the pain, paresthesia, sensory loss. It affects approximately 50% of the people with the considered morbidity and mortality and diminished quality of life. So painful symptoms such as burning, tingling, shooting, lancing presenting around 1/3 of the patient with the diabetic polyneuropathy and around the diabetic patients. So DPN start in the toes and gradually moves. So normally people will say some toes are getting numb, and then it gradually increases. So what is the pathophysiology? The main cause, what is happening in the diabetes, is the chronic hyperglycemia. So sometimes people say, I have the full control over the diabetes, doctor, why I am having this neuropathy? Actually, this patient, they have the chronic hyperglycemia, and then of course they are taking medicine, that is why control. So the timing is also important. If the people have the diabetes, they sometimes get this diabetic polyneuropathy. So chronic hyperglycemia seems to be the major culprit in initiation of various metabolic events underlying the diabetic polyneuropathy. The combination of there is a direct axonal injury due to the metabolic consequences of the hyperglycemia leading to the nerve ischemia. So one mechanism is the process of the reactive dicarbonyl formation, forming the advanced glycation and the produces AG due to the hyperglycemia. So if you see, it's a more of the complex, but simple way. If patient is having the hyperglycemia, and so that they have the loss of the insulin cycling, which causes the release of the kinase, redox sensitivity, and transcription factors. And this hyperglycemia can cause the iron homeostasis disorders, rapid lowering of the blood glucose, which is causing systemic inflammation process, which cause the oxidative and the nitrosative stress, which cause again endoplasmic and mitochondrial stress. And these patients are sometimes having that dyslipidemia, which is again a cause of the insulin resistance, or insulin resistance can be caused by the dyslipidemia. This all factor can cause increase in the cytokinin, chemokinin, IL-1 beta or IL-2, IL-6, IL-8, TN factor and CCL2 and CXCL1, which causes the infiltration of macrophages, and this again causes the neuropathy. This is again a very complex, but in short, the main cause of which are the factors affecting the neuropathy in diabetes patient is the chronic hyperglycemia, insulin resistance, then metabolic abnormalities, then this causes the oxidative stage, increased age formation, then it is causing nitric oxide PGI formation, then they have the hyperlipidemia, then they have the neuroforma. Then what is it causes the decrease in the MNC and SNCV, and then sensory blood flow decreasing, and this can cause the axonal atrophy or progressive demyelination. And again, this causes the decreased fiber regeneration, because nerves are always regenerative. But because of all this problem, there is a decrease in the fiber regeneration. Then there is a nodal and paranodal degeneration, and then neuronal damage. What are the clinical features? Normally, of course, patient will complain of some sensory symptoms of the diabetic, maybe negative or positive. So what are the negative sensory symptoms? The negative sensory symptoms include numbness. The patient will say chin 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 hota hai, deadness, or I cannot feel. Sometimes patient describe the feeling of wearing gloves and socks. So sometimes we say gloves and socks neuropathy also. And what are the positive sensory symptoms like tingling, burning, electric shock like sensation, aching, and hypersensitivity to touch or hyperesthesia? So these symptoms are peculiar of the neuropathic pain, and these both negative and positive symptoms. But sometimes patient has the less sensation, or patient may be having the hyperesthesia, and sometimes tingling, numbness. And so sensory complaint typically manifests initially in the toes and progresses to the upper limbs in a shocking and a gloves pattern. Because chronic DPN is the length dependent process, the sensory manifestation are most pronounced in the lower limb. It starts from the lower limb, then they involve the upper limb also. So neuropathic pain affect up to the 20 to 30% of the patients with the diabetic neuropathy, and it is one of the main reason for the patient who seek the medical care. How we can prevent? Because prevention is always better than cure. To screen all the diabetic patient. In fact, most of the hospital and clinics, they run these diabetic clinics where they normally screen all the patients for the peripheral neuropathy, and should be recommendation also. So all the people with the diabetes should be assessed for diabetic peripheral neuropathy, starting at the diagnosis of type 2 diabetes, and 5 years after the diagnosis of the type 1 diabetes, at least annually thereafter. So if patient is having the type 2 diabetes, then you should, starting of the diagnosis of type 2, you should do the screening, or if patient has the type 1 diabetes, then the 5 years after the diagnosis. Assessment for the distal symmetrical polyneuropathy should include a careful history and assessment, because everywhere history and assessment is very, very important to know that what is the patient is having the problem, or length of the disease. So we should have the either temperature or pinprick sensation. So all the people with the diabetes should have annual 10-gram monofilament testing, 10G monofilament testing to identify feet at the risk of the ulceration. So symptom and signs of the autonomic neuropathy should be also assessed when the people with the diabetes, when it is a type 2 diabetes from the start, or type 1 diabetes after 5 years. So autonomic symptoms like patient is having any urinary symptom and sometime other symptoms also. So screening can include orthostatic dizziness. Patient cannot feel how they are standing, or so they can feel. Sometimes they have the syncope, and sometimes they have the dry cracked skin in the extremities also. And autonomic neuropathy include orthostatic hypotension, resting tachycardia, or evidence of the peripheral dryness or cracking of the skin. So diagnosis of peripheral neuropathy includes patients with the type 1 diabetes more than 5 years, and all the individual type 2 diabetes should be assessed annually for the diabetic neuropathy using the medical history and simple clinic tests. You can see their feet, how they are doing, they have cracking or not, or they are having the dry skin, or patient has the tachycardia or not, or the orthostatic hypotension. And symptoms always changes with the sensory, what the sensory fibers involve. The most common early symptoms are involvement of the small fibers, and it includes pain and dysesthesia. So involvement of the large fiber may cause the numbness and loss of the protective sensation. Patient can feel when this disease is progresses from the small fibers, the disease goes to large fibers, they feel the numbness and loss of the protective sensation. So if the patient has a loss of the protective sensation, it indicates the presence of the distal sensory motor polyneuropathy, and they are risk for the diabetic foot ulceration. So clinical tests used to assess small and large fiber function and protective sensation. For the small fibers, we can do pinprick and temperature. You can see whether patient is having the heat and cold, how they are doing with the temperature sensation, or some pinprick. But for the large fiber function, we should do the lower extremity reflexes, vibration, perception, and the 10G monofilament test. And if patient is, we are testing with the 10G monofilament, then we are examining for the protective sensation, where the patient has the loss of protective sensation or not. And this is very, very important for diabetic patient, because if they have the loss of protective sensation, they can have the ulcers, foot ulcers, which go again very, then necrosis and then ulceration, then infection, and then sometime amputation also. So to prevent the amputation, sometime patient may not complain, but we should do annual examination as it is a protocol, so that we can protect patient from having the ulcer and further till the amputation. See, in all people with the diabetes, the diabetic neuropathy, cause of neuropathy other than the diabetes should be considered, as I said, because patient can have radicular pain because of the prolapsed disc. Patient can have the alcoholic. So alcohol can cause again a peripheral neuropathy. Sometimes neurotoxic medication like chemotherapy, is the patient is having any cancer or patient on the chemotherapy or not. Is the patient having vitamin B12 deficiency, especially in the vegetarian patients. Hypothyroidism is also caused for the neuropathic sensation or pain. Renal disease, advanced renal disease, they have the all the time this peripheral neuropathy. Some malignancy like multiple myeloma, bronchogenic carcinoma, infection like HIV, then chronic inflammatory demyelinating neuropathy, inherited neuropathy. Some patient has no cause, but they inherited the neuropathy. They will say, in my family, everyone is having this tingling numbness, and vasculitis. To manage, because once you diagnose, management is very, very important, because patients are coming for management to you. So recommendation from ADA is the first and most important is the optimized glucose control to prevent or delay the development of neuropathy. It is the most important. The patient should have the very controlled glycemic control. For the type 1 diabetes patient, to slow the progression of type 2 diabetes patient. Then optimize blood pressure and serum lipid control to reduce the risk or slow the progress of diabetic neuropathy. Because the hypertension and the lipid, as we said in the pathophysiology, they are also causing factor for the neuropathic. Then assess and treat pain-related diabetic peripheral neuropathy and symptoms of the autonomic neuropathy to improve the quality of life. What is the main medications which we use for the management of diabetic peripheral neuropathy, like gabapentoid, SNRI, SSRI, TCA, tricycline, and sodium channel blockers are the most recommended pharmacological treatment. And after that, if they are not controlled with the medication, then we can refer the patient to the pain specialist, where pain control can be achieved. So glycemic control, near normal glycemic control implemented early in the course of the diabetes has been shown to effective or delay or prevent the development of diabetic neuropathy. So BRA 2D trial showed that patient treated with the insulin sensitizer had a lower incidence of the distal symmetrical polyneuropathy compared to insulin or the sulfonylurea. So if you see, there are nowadays very advanced and newer drugs are available for the diabetes. So if we use the insulin sensitizer, then the neuropathy is can be delayed or less developed. Blood pressure control is very, very important for prevention of the development of the diabetic neuropathy. And as per ACCORD trial, intensive blood pressure intervention decreases or can the risk for diabetic neuropathy by 25%. American Academy of Neurology suggests the medications for the diabetic neuropathy start with the gabapentoid or the calcium channel blocker, SNRI, sodium channel blocker, TCA, and SNRI, or in last, if pain is not controlled with that, then the opioid dual mechanism for treatment of the diabetic neuropathy, which is gabapentoid are the main in the multimodal approach, or you can see the multi-medication or multi-drug approach. The gabapentoid is the main class of the drug that include gabapentin and pregabalin. Gabapentoids they bind to A delta, alpha 2 delta subunit of the calcium channels, and what they causes, they reduces the calcium influx into the neurons and thereby decreases the release of the excitatory neurotransmitter. These both are the FDA approved for the treatment of the painful diabetic neuropathy. So we can use pregabalin or gabapentoids to manage the pain of the diabetic neuropathy. Gabapentoids, pregabalin is the drug of choice for the treatment of the diabetic neuropathy, supported by 8 high quality and 7 medium quality studies. In fact, I will say for many years, we are using the pregabalin for the diabetic neuropathy and it has really good result. So one high quality study and many small studies support the role of the gabapentin in treatment of pain. 2 medium quality studies suggest that microgabalin has a small effect on the pain in the diabetic neuropathy. Adverse effect may be attenuated by lowering starting dose and more gradual titration. And especially in Indian population, I have seen some patient, they can't tolerate the pregabalin. So you can start, even we have the pregabalin in dose of the 50 milligram. So you can start with 50 and then you can increase the 75 or 150. You can use up to the 300 milligram the pregabalin. And sometimes they don't tolerate at all pregabalin, then you can start with the gabapentin. Again, gabapentin, the small doses like 100 milligram, and you can go, because the maximum dose even you can use the 1800 to 3600 of the gabapentin. But in Indian population, they normally don't tolerate. Whereas the serotonin and norepinephrine reuptake or inhibitors, NRI, the SNRI work by inhibiting the serotonin transporter and norepinephrine transporter proteins. So SNRI are believed to indirectly modulate other neurotransmitter systems such as dopamine and acetylcholine, which may also contribute their therapeutic effect. SNRI includes, what are the main SNRI? Duloxetine, venlafaxine, and deservenlafaxine. Normally, we use the duloxetine and venlafaxine. Duloxetine is the most commonly used drug for the diabetic neuropathy. So 2 high quality studies and 5 medium quality studies support the role of duloxetine for the diabetic neuropathy, whereas a high quality study support the role of venlafaxine in the treatment of the pain of the diabetic neuropathy. Again, to prevent the adverse effects, we can start with the lower doses like duloxetine. You can start with the 20 milligram and you can increase gradually. Whereas the tricycline antidepressant, TCA, they act by inhibiting the reuptake of the monoamine neurotransmitters, include norepinephrine, serotonin, and dopamine, which is result in increased concentration of this neurotransmitter in the synaptic cleft, which enhance the neurotransmission and the mood stabilization. So if you give the TCA, most of the patient now, they are the teach by the Google, and they will come, why you are giving, I don't have any depression, why you giving the antidepressant? So you have to make them understand these are not antidepressant. They work on the pain pathway and we give in the low doses, whereas the antidepressant doses are very, very high. So you have to explain the patient. Otherwise, they will read about the medicine and they will come. So tricyclic antidepressants have been extremely studied for the treatment of pain. 2 high quality study and 2 medium quality studies support amitriptyline for the treatment of the diabetic neuropathy. In anticholinergic, side effect may be dose limiting and the restrict use in the individual more than 65 years. And you can start with a very, very less dose like 10 milligram, which has really very, very minimum side effect. Whereas the other opioids like medicine like tapentolol and tramadol, they have the centrally acting opioid analgesic. They act through both the pathway like the mu opioid receptor agonist and norepinephrine and serotonin reuptake inhibitor. So they are acting by the two pathway. So SNRI opioid agents are probably effective in treatment of pain in diabetic neuropathy. Use of any opioids for management of the chronic neuropathic pain carries the risk of the addiction and should be avoided. So it is not a first line of choice or the second line of choice. It should have the after when you exhaust with the other med drugs, then you can start with the tapentolol or tramadol. But normally you should not give continuously because patient can be addicted. In fact, I have seen patients are very much addicted with the tramadol. So tapentolol, because it's not so popular or common, the patient has a less addiction with the tapentolol, but the very common, the addiction problem in for chronic pain, if they use the tramadol, they are having this problem. We have the some other third line of the drugs also, like capsaicin. And capsaicin has received FDA approved for treatment of diabetic neuropathy, and it is a 8% patches. So one medium quality study shows the 0.075% capsaicin cream has been reported. So you should be but very careful about prescribing the capsaicin 8% because the patient has the burning pain sometime as a neuropathic pain. And if you give the capsaicin, they start more burning, and this can really cause very much problem. So you have to be very careful about prescribing and you inform the patient about this. In clinical pearls about the diabetic neuropathy, so diabetic neuropathy is a fairly prevalent complication of diabetes that need to be carefully controlled in order to keep the condition under control and avoid it crippling repercussion. Glycemic control and pain are crucial component of therapy that should not be ignored. All people with the diabetes should have annual 10G immunoglobulin testing to identify feet at risk for ulceration and amputation so that they can prevent from the amputation. Patients with the diabetes, type 1 diabetes duration more than 5 years and all individuals with the type 2 diabetes should be assessed annually for diabetic neuropathy using the medical history and simple clinical test. Optimize blood pressure and serum lipid control to reduce the risk or slow the progression of diabetic neuropathy. AN suggests gabapentoid, SNRI, sodium channel blockers, TCAs, and SNRI opioid dual mechanism agent should be considered in the treatment of pain in diabetic neuropathy. Actually, with the this patches, we have this lignocaine patches, also 5% lignocaine patches. They are if patient has a very small area of the pain, then you can prescribe the lignocaine patches also. Thank you. And if patients are having more pain, you can actually send the patient to the pain physician. We have some intervention pain management which can work for these diabetic neuropathic patients.
Thank you. Thank you, Dr. Krishna, for a very crisp and an enlightening talk. So there are some very good questions from our audience. So I'll go about with them one by one. So there's a question that in patients with diabetic peripheral neuropathy, what impact does glycemic variability have on nerve damage?
As I have seen that glucose level, if patient is exposed to hyperglycemia chronically, then they causes the nerve damage, axonal nerve damage, which has the more impact on the diabetic neuropathy. And duration is also very important. So if patient is exposed to the hyperglycemia for long time, they are more prone to having the diabetic neuropathy.
Okay, so next question is, should we treat DPN which is not painful? And if yes, then how should we treat it?
So if patient, as I said, there are sensory symptoms, two types, negative and positive. So if patient is a negative symptom, means there is a no pain, tingling, numbness, then you have to treat, like you have to be very careful and examine so that you can prevent it, whether the patient has the loss of protective mechanism or not. Because if patient has a loss of protective mechanism, then they can go under the ulceration and then amputation. So you have to tell patients, you have to make aware the patient. Maybe you don't give them the medications if they don't have any pain, but treatment is very, very important for them.
Yeah, so only if they have pain, then there is role of these medications, which are the positive sensory symptoms. But
Yes.
there are negative symptoms like feeling of deadness of the skin, or
Or
feeling of rubber
yeah,
sensation in the sole and all.
or gloves, yeah,
Yeah,
and
glove and
stockings.
stocking. Yeah,
Yeah.
yeah. So those patients should be very careful about because since these are the negative symptoms, they might not be aware of any injury which is happening to them in their foot, and ultimately it can lead to a diabetic foot, and ultimately it can lead to an amputation. So very good point that you said, that only when there
Yeah.
are positive symptoms we need to treat with medications, but we need to be meticulously following them up even for the negative symptoms.
Yes.
Okay, so the next question is effect of nortriptyline on DPN only due to its psychological effect, or are there other benefits also?
No, as I said, the TCA, tricyclic antidepressant, they are in class of the antidepressant, but the doses which we give, because they work on the negative pathway, reuptake pathway. So it work on the pain pathway, not as an antidepressant. If you prescribe this medication as an antidepressant, they have very high doses. What the doses we prescribe, it work only on the pain pathway, reuptake pathway, where they prevent to finish with this neurotransmitter, which can help in reducing the pain.
Excellent. I think very nicely you explained that in lower dosages, which is used for peripheral neuropathy. So they will be inhibiting the descending pathways, and when they are inhibiting, they will increase the availability of the neurotransmitters, which are inhibitory to the pain.
Yes.
So they not only their role is basically as an antidepressant also, they might have some, but their main role is in inhibiting the descending pathway.
Yes.
Okay, so the next question, is it advisable to start monotherapy like pregabalin as initial therapy, or should we start directly with a combination therapy?
It depends. If the patient has the only mild symptom, you can start as a monotherapy with the pregabalin, and if you don't tolerate, then gabapentin, and sometime combination. I prefer to start with the combination. Why? Because then doses decreases. Because the one monotherapy, if we start with the monotherapy, we have to give higher doses. And Indian population, they normally don't tolerate. They will start, side effects, ki mata ghum raha hai, ye ho raha hai, wo ho raha hai. So it is always better. We can give the combination, and so the doses are decreased for individual medicine.
One more thing which I feel regarding with respect to this question is that if we start, it would be a not generalized advice, but again it would be a case specific. But what I feel is in patients who are having sleep abnormalities,
yes,
probably those are a better candidates to start with a combination therapy, so that once the pain will be reduced and their sleep will also be normalized. So probably in cases, a combination therapy would be better to be started directly rather than a monotherapy pregabalin.
Actually, this patient, you rightly said, they come and they say कि अब नींद बहुत अच्छी आती है.
Exactly.
So
And what I feel is, if the sleep is good, it normalizes lot of things.
Yes. Quality of life increases. They feel better. In daytime, they don't feel exhausted. Then stress is less. Their sugar level can be controlled better way. So in overall, you are preventing or treating the diabetic neuropathy if glycemic control is good.
Right. Very nice. Okay, so the next question is very important question with regards to pain physicians and pain specialty. Where would you use opioids in the management cascade of DPN?
Normally I will not suggest opioids initially or in between, because again, it is a chronic problem in diabetic patient, and they can have the habit development. with the this opioid. So if the pain is not controlled by the all 3-4 class of the medications which we talk about, like gabapentin, SNRI, TCA, then you can, or if the patient sometime had the exacerbation of the pain, acute exacerbation, then you can give for the 2-3 days or 4 days, and telling them not to take more than that. So you should specify, if you are prescribing the opioid, you should specify this medication for 3 days, 5 days, or SOS, or for this period. You should not write, okay, to be continued, to be continued. Then these patients will, of course, let with the all the habit formation. And in fact, many places, they even ban the tramadol. If you Southeast Asia, if you Saudi and Dubai, they can't take the tramadol. That is banned. That is again, they say so you have to be very careful.
So even in India, this tramadol is a scheduled H drug, and
Yes.
without a sealed prescription, signed and sealed prescription of a doctor,
you can't
procure it over the counter.
Yeah.
So if I sum up this particular question, so maybe for an acute exacerbation, you can add an opioid initially for maybe 3 to 5 days, so that the pain reduces, and by the time the effect of antipsychotic medication starts.
Yes.
But not for for an established chronic pain, opioid might not be a good choice to begin.
Yes.
Okay, so one last question: are you using any digital monitoring or technology to improve patient management?
Digital monitoring means what type of the monitoring?
Actually, the question is not, I mean the monitoring of diabetes or monitoring of diabetic.
Of course, patient, we always manage the patient, and they should we monitor the blood glucose level, and they should have the diary, maintenance of the diary, and we see that is there. Or if the patient has a symptom, because there should be like a diabetic patient, the chronic problem, so they should have the card where we can put up sensory motor examination if patient develop, or when they are developing annual examination, that can be. But other type of the digital, I don't know about that, what type of the digital.
Right. So one last question. So as you are a pain physician, madam, suppose all these things, they fail to give good relief to the patient. Have the glycemic control is very good now. HbA1c is well maintained for the patient's age, but still patient is having a lot of positive symptoms of diabetic neuropathy. Patient is having pins and needle sensation, burning sensation. Is there anything beyond the glycemic control and medications that you can help these patients?
Yes, Dr. Pravesh, you are rightly said. In the pain management, the intervention pain management is also very important part of the algorithm for the pain management. If patients we are not able to control, of course, we'll try to control with the other things like glycemic, and then again physiotherapy and everything. If they are not controlled, so we can give some intervention, MIPSI, minimum invasive pain and spine intervention, like sometime doing the lumbar sympathetic block, or maybe the spinal stimulator, or maybe intrathecal pain. These are the 3-4 things. So if patient has the lower limb, because most of the common problem is the lower limb, and rarely then it goes to the upper limb, but upper limb problem comes very rare and lately. So if patient has the lower limb, so you can go for the diagnostic lumbar sympathetic block, because these symptoms and neuropathic pain symptoms are the sympathetic mediated sometimes. So we can block sympathetic chain according, and after doing the diagnostic block, if patient has the good result, positive result, then we can go for the radio frequency listening of the lumbar sympathetic ganglion, depending upon the what level patient is having pain, and that way we can control. But sometimes these patients are really not controlled by all these things also. Then we can go for the advanced pain management, that is a spinal stimulator. So where we put this, like we have the like cardiac pacemaker, we have the spinal stimulator also, which work on the gate therapy. Means so when they have the small sensation continuously, sensory stimulation to the dorsal horn, so that control the pain signals. So again, here also we do the first diagnostic, like we have do the trial blocks. If patient is positive with the trial, then when we can put, and these are quite long-term therapy, you can give even lifelong also. If not, then as we are talking about the opioids, we're talking about the opioids, oral opioids can make the habit, but if patient's pain is not controlled, then we have option of the intrathecal pumps also. So if you compare 300 milligram of the morphine, then we require only 1 milligram of the spinal, this intrathecal morphine, because it work on the intrathecal directly opioid receptor. So we can put the pump where small doses can be given on the spinal level and pain can be controlled. But these are really very, very advanced pain management. When we exhaust with the everything, then only these two treatment it comes in the picture. Otherwise, sometime, most of the time, the lumbar sympathetic blocks can also manage the pain. But we have to continue with the glycemic control and other therapy. You should not jump. You cannot. You have to do first them.
So as we understand, so there is directly not a primary indication of a lumbar sympathectomy or diagnostic lumbar sympathetic block. And then if the medications, they have their own role, and only after we have exhausted all of them and still patient suffers a lot, then we can advise the patient to maybe go for that. And as you rightly said, the pain may be sympathetically mediated. So if the pain is sympathetically mediated, then the lumbar sympathectomy, diagnostic lumbar sympathectomy might give a positive outcome. And if positive outcome is there, then we can go for a lesioning of the lumbar sympathetic chain by applying the radio frequency waves and by doing a radio frequency ablation. Yeah. So I think, Dr. Krishna, this was a wonderful talk. And
I think so.
and very good questions came up, and I think you answered them very nicely. So I thank you for all your time, and over to Mr. Aman for the rest of the proceedings.
Thank you. Thank you, Pravesh.
So, well, this brings us to the end of this very educative and interactive session. I'm sure the audience would have gained a lot from today's discussion. A big vote of thanks to Dr. Krishna Poddar and Dr. Pravesh Kanthed for sparing their valuable time and being with us here today. I would also like to thank our educational partners, IPCA Laboratories and CMA partners, Spirent Communication, for conducting of the program. So happy weekend to all until we meet next again.
Thank you so much. Take care. Bye-bye.
Thank you, ma'am. Thank you. It was a wonderful session, ma'am.
Thank you.
So we'll send you the link if somebody wants to watch it later on. They can
Of course, I'll share to them.
Sure. Thank you.
Thank you.